Welcome, everyone. Thank you all for joining us for our first Meet the Doctors Zoom event in March 2024. The Minnesota Endo Warriors are a nonprofit volunteer group that are focused on advancing care and empowering endometriosis warriors through advocacy, education, and support. Today, we have Dr. Palmer with us from Oakdale OBGYN. Dr. Palmer has been with Oakdale for 10 years and has extensive training in endometriosis, uterine fibroids, pelvic organ prolapse, and chronic pelvic pain, as well as advanced surgical training. Now he will give us a little bit of information about after he moved to Minnesota after completing all of his training.
When I moved to Minnesota, there was, not a lot of people doing comprehensive endometriosis management. I found very little evidence of people doing excision-based surgery or tackling difficult cases, and a lot of patients were, they were finding care maybe at Mayo or a few places, but it was not. There wasn't really a lot of options for people, and honestly, there still isn't. But what I try to provide, and we can talk a lot more about this as we go into the questions, but is a practice that has a focus on kind of comprehensive management of endo and trying to take a multidisciplinary, holistic approach to the disease. And that includes surgery, and it includes, sort of a excision-based, comprehensive, try to be very thorough type of endo surgery, but also includes other aspects that I think differentiate the care that we can provide from a lot of other places. So I'm excited to kind of answer a bunch of questions tonight that have been submitted by you all, and gathered and sort of gone through and narrowed down and honed in by the hosts here. And hopefully kind of in a broad way we cover much or all of the things that you guys want me to, and then we can have some opportunity for some write-in questions too as time allows. And when is our end time, Alamanda? Is it 8?
So we have an hour and a half.
Hour and a half. Okay. Okay.
Yep.
So we'll just keep rolling, and cover as much ground as we can.
Sounds great. Yes,
yeah,
we
go ahead.
received a lot of questions. So
Okay.
Kate and I summarized them, and hopefully these will answer a lot of questions, as Dr. Palmer said. So you kind of explained, what led you to learn about endometriosis, but a follow-up question to that is, why do you continue? Because we know it's not an easy disease to manage.
Yeah. Well, I think probably the best answer is that I really see a lot of value in this type of work. I think that, I've seen many success stories, and it's been very rewarding to be able to do work with endometriosis patients. And there's a lot around that. Generally, while these cases can be difficult, and chronic pain, it can be difficult to manage, I think that I found it to generally be a group of people that are strong advocates for themselves and for their health care, and are willing to engage in the process with you to be able to, achieve outcomes to the goals that they're trying to achieve. And it's just really very rewarding as a doctor to see somebody that's dealing with so much be able to be helped. And things like fertility journey is also a big part of this for many people, and seeing people be able to have successful pregnancies and deliveries is very exciting. Seeing the ability to live a better quality of life and work, and have meaningful family lives and things is super rewarding. And so I think it's just the success, and seeing that what I'm doing and the way I'm doing it, and we as a team are doing it, is making a difference. And that just keeps me going. I mean, I didn't ever think that it would kind of become what it has become as far as the volume and kind of the wide range of patients that we see from really all over the country, um, that are dealing with endometriosis and not able to find the care that they need elsewhere. And so, it's I guess surprising to me all the time when I see people of how far they drive or fly sometimes, and just the expense and the time and the hours they put into to trying to get care for the symptoms that they're suffering with. And I'm just trying to help. So I think it's
Mhm.
just really rewarding work, and it's kind of never ending. It's kind of a self-perpetuating type of process where I would say the majority of my patient volume comes from word of mouth and from friends, relatives, people that have had, care that they've appreciated, and talking to someone else with similar symptoms and saying, hey, you got to go see Dr. Palmer and his team or whatever. Um, and so I think it's just kind of one of these where I've just seen so many people that know somebody else that's referred them, and it just kind of keeps rolling that way. And thankfully now I get a lot of referrals from OBGYNs and from other and primary care doctors that recognize that, a patient's symptoms are something that they don't want to or don't have the skill set to tackle, or know that they could potentially have a better outcome somewhere else, and then they send them on to me. And that's been also really rewarding to be kind of a go-to person in this community for being able to provide good
Wonderful.
endo care. Yeah.
Wonderful. Thank you. Yes, and like you said, you guys are moving kind of towards the team approach. I mean, you
Yep.
direct that. You have the nutrition, physical therapists, as well as you guys have a new questionnaire that you've implemented,
Yep.
to kind of help with that process. Could you explain a little bit more
Sure.
about that for everyone?
Yeah, so many of you have probably seen some of the promotional stuff that we've done with Oakdale, and also maybe with what the Endo Warriors. I don't know if you guys have promoted it yet or not, but
We haven't yet.
haven't. Okay. Essentially, the concept is, and kind of taking the lead from other centers similar to ours, and trying to be a little bit more thorough with information gathering on patients when they're coming into the practice. And so myself, Dr. Jenny Zhang, and Heather Lunning, our PA, are kind of trying to be the face of Team Endometriosis for Oakdale. And we kind of put together this questionnaire from a number of different resources that's going to basically allow us to um, really have a really detailed picture of what people are dealing with when they're coming in to the desire to have an appointment or a consult for pelvic pain or endometriosis. It's a questionnaire that goes over, things like personal history, menstrual history and issues, GI symptoms, bladder symptoms, sexual health symptoms, you know, past surgical experiences, meds, doctors you've seen, et cetera, like lots and lots of detail. And what we're trying to do is to um, understand people coming in as best as possible so that we don't have to spend a lot of time de novo gathering information that we could have coming in. It makes the process more streamlined, and it allows myself and Dr. Zhang to have the best information for you all so that we can know how to direct care best. How um, urgent is the situation. Sometimes, what was happening is we were getting patients that would call and they would say, I have pelvic pain, I want to see Dr. Palmer. And they were just kind of given the next available slot. And there really wasn't any understanding of, there was a lot of confusion about why were they having pelvic pain? Was it a bladder issue? Was it fibroids? Would they have heavy bleeding? There was different things that weren't properly really being sorted, I think. And it was, for me, I want to make what I do the most impactful on people that need it the most as possible. And I don't know that from looking at a piece of paper about somebody, of course, but it's just a way to try to flesh out what someone's dealing with a little bit more detailed so that I can have as much information as possible. And sometimes through those questionnaires, I might say, I want this person to see Heather first. And, usually those are people that are younger that really haven't had any care for endo or really any, kind of a workup or anything at that point. And, the people that I know need advanced surgical care. People are coming in with big endometriomas with multiple prior surgeries where we know there's endo everywhere. And I mean, whatever the story is, those are the people I want to say I need to get on my schedule ASAP. And so everybody's important. Everybody, will have a place and will be seen in when we can. But I think it's just trying to kind of figure out how to deliver the best care in the most efficient way possible is kind of the gist. So it's not a perfect system. Basically what happens is patients call the schedule, the schedulers let them know this is our process, and they send them the form via email or mail or whatever's best for them, text, and then they are told to call back in when they have their form completed and send it back. And then at that point, they're given an appointment basically. And when they send it back, it's reviewed by myself and by Dr. Zhang. We're kind of taking like a week at a time, where we're kind of reviewing all of these in detail, making detailed notes, talking with each other, and then making recommendations about where patients should fit in. I don't think we would ever not see somebody. I've heard other places where they say, oh, you don't qualify to be seen here or whatever. I mean, I don't think that that's ever going to be the case, but it's just a matter of kind of triaging in a sense. So one point of clarification that I've heard some feedback on is that people are getting the questionnaire sent to them and then calling in and saying, I'm ready to be scheduled now. And they're being told that, okay, we'll get you on for first available, which is several months out. And that's been a dissatisfier. And so I think what people need to understand is that there's still going to be a wait to be seen. Once they turn in their questionnaire, we're just trying to, use that as a launching point for having as much info as possible before they're eventually seen. So.
Yeah, I know that would have helped. I started my journey with Dr. Palmer 5 years ago, and I brought in a stack of paperwork, and I couldn't
Yeah.
even find what I wanted to tell you versus you finding what you needed to know at that first
Yeah.
appointment.
Yeah. And when you do a release of records from whatever doctor or health system you've been at, they'll basically send everything from, your tonsil surgery to your whatever, obstetrical history, things that are kind of about you, but not necessarily relevant to the current situation. And so it's a little bit harder for me to take a stack of 500 pieces of paper before I walk into a 30-minute consult and expect to have it all collated, assimilated, and read and studied and ready to meet with somebody. So, it's just, again, trying to help me and be more prepared. Yeah.
Mm-hmm. Yep, absolutely. Thank you. Yeah, and we'll be talking about that more in the endo group as it kind of rolls out. If anyone has more questions, of course. But it's all, in an effort to reduce wait times eventually to help
Yeah.
get more people care.
Yes.
And so that's, and help understand your background the best as possible.
Yep.
So, yep. So one of the things that comes up a lot in the Endo Warriors group is individuals who have come to see you or another physician, maybe they've already scheduled excision surgery, but they are, there is a fear, obviously, of having surgery usually, and some of that fear is also related around whether or not you'll actually find endo. And so I'm curious, how do you kind of help walk people through that?
Yeah. I mean, it's very normal to have anxiety about surgery, obviously. Nobody wants to have surgery and nobody would choose to do it. And of course, nobody would choose to have the symptoms that they're having if they could help it. So I think, the reassurance that I try to provide is that, I'm gonna be able to provide a skillful approach and do the best that I can to be thorough. And, generally the outcomes of most people are safe and positive. And, I think, what you want in a surgeon is someone that's, competent and confident with what they're doing, has a lot of experience. And so just that helps. I think just try to, um, you know, display, then convey that confidence that, what I generally, I try to know as much as I can about what I'm going to find when I get in there, but ultimately with the nature of endometriosis is that one can't really know unless it's sort of directly seen and dealt with. And so it's kind of a see and treat diagnosis. And because of that, I have to really be able to be comfortable with a lot of different scenarios and, um, manage things that just are unexpected sometimes and difficult related to the bowels, the bladder, the ureters, a lot of adhesions and nerves and working around big vessels and, things where it's sort of like the danger zone areas. And that just comes over time and experience and seeing lots of different things. So I think from that perspective, hopefully I can be reassuring to people when we're talking about surgery. And then, the idea that, we have a really good team. We have a really consistent team. The hospital experience that most people experience at Maple Grove, where I do most of my surgeries, is generally really good feedback. People generally feel very cared for. They feel like everyone knows what they're doing, and they feel like it's a good experience when one has to have surgery. So I think that's helpful. The idea of I get probably asked 5 times a day. I wouldn't say that. Maybe let's say 2 times a day. What if you don't find anything? You know, and so sometimes when we're looking at a set of symptoms, we have to kind of make an educated guess about what it means, especially with endometriosis. And so my goal with my approach and the thoroughness that I try to bring, and something like the Endo questionnaire helps that, but is to try to have the best possible knowledge that I can, that what someone is describing to me makes me feel really confident that it's related to endometriosis. And one of the things with endometriosis is that it can have a wide array of symptoms. And while a lot of people have similar things, not everybody has everything, and some people have more than others. So like whether it's related to the bowels or the bladder, or, pain with intercourse, or, GI symptoms, bloating, blood in the urine, blood in the stools, all these kind of things that sometimes people describe, it kind of gets generally throughout the course of the conversation and in my mind, until we know otherwise, it kind of gets lumped into that endometriosis bucket. And it kind of, a lot of things fit together and it kind of makes sense. And then sometimes when we get in there and you don't necessarily find what you're expecting to find, I tell people that, number one, my priority is to continue to help you and help you figure this out. So we're going to continue to pursue avenues that we need to try to get the information that we can, whether it be a referral to somebody else or further testing or whatever. And then, I try to reassure them that at that point, we're going to try to get a little bit more granular with the symptoms. And so then we can say, okay, if it wasn't endo on your bowel and that symptom is not getting better, and we're, a couple months out from surgery, let's think about something else that could be causing those symptoms. And, so it's, I think it's trying to have the best understanding going in. And I feel like when I talk with people about their symptoms and I feel really confident, it's because I've seen and talked to so many people that have similar symptoms that it makes me feel reassured and to say, you have endo, I mean, this is basically nothing else that could really have this combination of symptoms that make sense, but Sometimes it's a lot more vague than that. I mean, this is, this is not a black and white, cut and dry kind of deal, and as you all know. So I say that kind of all with a caveat of I try to do my best to make the right decisions for who I'm going to take to the OR. I'm not somebody that is an advocate for repetitive surgeries. I try very hard to minimize surgery necessity and recurrence. So, we try to do the best possible first surgery that we can. And sometimes for some people, that's their 10th surgery, but, hopefully it's not. And we're able to achieve a result that is, from a surgical perspective, hopefully the only one that they need. And, that's kind of a loaded concept because we know endo is and can be recurrent. And certainly people can need repeat surgery, but I think what we're trying to do with excision-based surgery and in the comprehensive nature of it is, statistically, when you look at data comparing ablative surgery, cauterization of superficial disease, surgery being done by somebody that doesn't do as much compared to a high volume endosurgeon that practices detailed excision, you're going to see better outcomes, lower recurrence rates. And that's kind of what I try to also describe to people, as a reassurance point. So
Yeah,
that
no,
help?
that's really good to kind of, if we don't find, yeah, that does help. I mean, if you don't find endo or you don't find it where you thought it was, keep asking and you're willing to,
Yeah.
stay on that journey of keep figuring out what's going on. I think that's really
Yeah.
helpful.
And one of the other points
And
about that too, sorry, Alamanda, is just that, we know that
you're
this
good.
is a disease that after surgery, the pain requires some time to, and usually a multidisciplinary, multimodal management strategy to really get the best result. So people sometimes, they come back and see me at their 2-week post-op visit and they're like, I can't really tell. I feel the same, Um, and I just try to encourage people to give it time. Usually there's I try not to see people back after that 2-week visit until about 3 months out is what I usually tell people because I want your body to go through a couple cycles. I want you to be able to do some pelvic floor physical therapy if it's indicated. I want you to be able to figure out the hormonal strategy that's going to work for you if it's indicated. And then, we kind of meet again to fine tune things after another couple months have passed. So I think that's an important point is patience with your recovery and with the long-term plan is really necessary.
Yeah, I think that's a good point, and that kind of brings back up another question that's further down our list, but we'll bring it up right now is, what do the most successful patients do post their excision surgery to kind of delay further surgeries? I mean, I know you listed a few, but
Yeah.
are there anything else that you've kind of seen?
Well, I'll say that every patient's journey and management plan is unique. So there's not really one thing that we always do for everybody that's going to work. And so I try to really take an individualized approach, and a lot of it depends on a person's goals, whether they be fertility goals or functional goals or both. And, the goal is to try to come up with a plan that allows the person to get to achieve those goals as best as possible. So of course, if someone's trying to get pregnant, we're not going to start them on a hormonal approach right after surgery generally because we're going to try to get back into regular cycles and going down that road of whatever that looks like for them as far as trying to conceive. If somebody sometimes we'll try to do suppressive hormonal therapy to try to stop periods from happening because generally people that have endo tend to feel better when they're not menstruating. And so usually we'll work on a plan for that if that's the goal. I really try to have a kind of a wide range of options. And I try to always talk to people about, are we in an action phase right now, or are we in a maintenance phase? And so usually after surgery, we develop a maintenance plan. And the maintenance plan is typically kind of three different categories: hormonal, anti-inflammatory, other type of pain management, including rescue pain management. And that can include things like muscle relaxers, vaginal suppositories, sometimes other types of pain medications, which I try to avoid opioids for. And then, ancillary things that help. So that could be physical therapy, it could be acupuncture, massage. Sometimes there's a significant mental health component that needs to be addressed for a lot of people. And so that is something that we're still working on, because it's a difficult process in any avenue of medicine right now, is to try to get somebody mental health help that they need. But I think that's a part of it. At least it's a part of the conversation for a lot of people. And so, just kind of thinking about each person's symptoms and their goals in an individual way, and then designing a treatment plan that's going to help meet those goals, and walking through those different aspects and coming up with ideas. I usually tell people I'm rarely out of ideas, and I want you to follow back up with me to try something else if what we're doing is not working. And I'm also a big proponent of not changing a ton of variables at once, because I want to be able to kind of understand what's working and what's not for people. So, all of those things kind of taken into consideration, I think the bottom line is that we've got a lot of different things, both from a medicine and kind of functional process that we try to do to implement to make it as successful as possible. I forgot to mention, it also includes a nutritional approach and anti-inflammatory strategies, both for eating and supplements. And I usually rely pretty heavily on my dietitian, Kim Plessel, who has seen thousands of endometriosis patients now over the last 10 years, and is very competent and well-versed in anti-inflammatory strategies, and has helped a ton of people.
Yeah, I know. I started to see her while I was waiting for surgery, and that was very helpful.
Yeah.
So she's fantastic. What? Okay, so two other questions then, kind of relating to the endo symptoms and locations. So there are obviously individuals who have had surgery, have had a hysterectomy, and
Yep.
then, they still have pain, they still have symptoms. How could you identify that pain after a hysterectomy and know that, okay, it's still endo in there?
Mm-hmm. Well, I think a lot of people, just to kind of talk a little bit about hysterectomy, a lot of people have sort of misplaced guidance into getting a hysterectomy, to say that that's going to cure their problems, without really fully addressing the disease that also involves the rest of the pelvis. And I think most of us know that you can't just do a hysterectomy and expect endo to go away or to be cured. And so I try to help people understand that point. And then, I think trying to really get a good history of the why did they have their hysterectomy, and what were the symptoms that led up to it. A lot of people that have hysterectomies probably have adenomyosis, which is sort of a related disease state to endometriosis, and it's probably the most common pathology diagnosis that you see on uteruses after hysterectomies, because most people that are getting hysterectomies are doing it for bad bleeding problems, and pain and dysmenorrhea. But generally, endometriosis remains cyclic in some way for people, regardless of having a uterus. So we can often identify patterns of things that seem to be related to inflammation, and pain, maybe when that person would have had their menses, in the past. And that's a helpful tool to kind of do a detailed history and ask the right questions. Um, and so I think it's still just, if there's unresolved pain, after hysterectomy, it's always kind of trying to go down that road of are we in a maintenance phase, or are we in an action phase, you know, and are we kind of needing to do a further surgical approach to address unresolved, unresected, undealt with disease. And that can be partly sorted through conversation, through exam, through ultrasounds, through MRI sometimes, through different modalities to try to sort that for people and help them make the best decision if it makes sense to go in again surgically versus, hey, let's try to just change the paradigm for what you're doing medically right now, you know, to see if we can get a better quality of life result. You know, obviously you've made the decision at that point to not, you know, have more children through conceiving, you know, with a uterus. And so, you know, then it gives you some more latitude to make some more hormonal decisions and things like that sometimes for people. So it's still kind of dealt with in the same way with or without a uterus. It's just a matter of asking the right questions and trying to figure out if it makes sense to take further action or design a better maintenance program.
Okay, gotcha. And then from your experience, you know, where all have you seen endo in patients?
Well, I would say generally endometriosis tends to be isolated to the pelvis. Now, tends to that's taken with a grain of salt, but that's most commonly you're going to see it, you know, in the posterior cul-de-sac, around the bladder, on the pelvic sidewalls, around the ovaries. But I certainly see my fair share of endometriosis on the diaphragm and on the upper abdominal bowel area. I've definitely seen endometriosis in the chest cavity. Um, you know, we've seen a lot of people have, when I try to help people understand their pain, a lot of people have pain like in their legs or their feet, or their arms or different things, and they think, oh, I must have endometriosis in my elbow or something, right? I mean, you know, something, but probably you don't. Probably it's a referred pain from a nerve source that's being irritated by the inflammation caused by endo in more in relationship to your abdominal cavity. So, you know, I hear stories of endometriosis in eyeballs and brains and things like that. And, you know, I think it's certainly possible. And I know those case studies are out there. I just don't tend to see a lot of that. And I think part of the problem is we don't fully understand how endometriosis spreads and why, you know, and so there's different thought processes related to like direct contact of cells with tissues versus more of a bloodstream or a lymphatic transport kind of concept. Um, you know, my experience would tell me that it generally involves some element of those cells actually touching the tissues and growing into them in an abnormal way. Maybe that's from conceptually somewhat related to retrograde menstruation, where you're getting some menstrual blood that backs out into the pelvis. And then, you know, but likely that happens to just about every menstruating person. So why do people that have endometriosis develop it? That's the part we don't understand. And why does it take on more of an autoimmune type component in some people when other people just clear it naturally without ever knowing that it happened? And those are, you know, unanswerable questions right now, but we're, you know, trying to understand the why of it more. But we probably have less answers about endo than certainly than we have questions. I mean, you know, so I think it could be anywhere, but it's likely to be more related to the pelvis, and then most pain outside the pelvis is referred pain. Not universally true, but most.
Okay. Yes. And then now endometriosis in general, people think of it as being, you know, estrogen dominant disease. Could you kind of explain a little bit, you know, about how hormones play into endo, not just estrogen, but progesterone, testosterone, all
Yeah.
of those?
Well, we know that endometriosis grows and proliferates in people under the influence of estrogen in their body. So while all those hormones do interplay together to basically create a person's menstrual cycle, ovulatory function, building and shedding an endometrial lining, preparing your body for pregnancy, maintaining a pregnancy, sex drive, homeostasis of your body, all those things are like in the mix of what those different hormones do at different times and at different levels. But ultimately, probably the key to endo is estrogen. And so, you know, sometimes when we're designing a strategy to treat endo, we're talking about trying to reduce estrogen because generally from data that has been done related to trials and things like Oralisa and other medications that are generally designed to block the output of ovarian estrogen, pain pain reduction is achieved largely by lowering estrogen levels when it works for people. So I tend to kind of throw around the idea with people that have endometriosis often have sort of high estrogen levels, or they're estrogen dominant, or they really are affected and influenced by estrogen in their body specifically. They often tend to have a lot of cyclic systemic symptoms as well, like headache, nausea, breast pain, different kind of migraine, aura kind of things. A lot of people have commonly that have endo have those things, and fatigue, big one. Um, and, so a lot of that is if we can cut down on the systemic estrogen in some way. And so there's a lot of things around that. I mean, I could talk about a lot of different things about that, but essentially sometimes it's surgical. Okay. So sometimes I think you can achieve a bit of an estrogen modulating concept sometimes by debulking endo, because endo makes estrogen. It makes its own estrogen, and it proliferates itself by making estrogen. And so that can be helpful in removing that with good detail. Sometimes hysterectomy or removal of one ovary can help also modulate the overall output of estrogen for people. And so that's one idea. Certainly hormonal approaches, what we're trying to achieve there is kind of, and really the idea of birth control, quote unquote, use that term loosely, but hormonal management is to sort of mimic a pseudo pregnancy state. Okay. And so what's happening during that time frame is that your hormones, as they're regulated by the placenta, are steady and regular to support a growing pregnancy. And so when you're not subjecting your body and your endo to fluctuations and high levels of estrogen at times, you're generally going to see a reduction in symptoms by keeping things moderated, low, and steady. And so this is typically why people do better on continuous hormonal strategies, continuous birth control, skipping the placebo pack, skipping periods, because they're not subjecting their endo to estrogen changes that are then causing it to flare sometimes and be calmed down sometimes and go back and forth. And that tends to just drive inflammation in the body. So I want to emphasize with this group that, well, I think surgery is paramount to success. I also think that hormonal options and hormonal management is key. And the idea that we want to take a multidisciplinary approach is really important. So I try not to throw out I get a little bit wary when people talk about hormonal approaches being bad or not helpful, or because it's really not just about one thing. It's about designing a plan that's going to work for that individual person, and it could and probably will include some type of hormonal moderation and modulation management plan, because we're really looking at it from a multidisciplinary approach. So, that's that's kind of a little bit of the deal with hormones. I mean, I don't know if there's probably
Yeah.
more to
I-
unpack there, but kind of off the cuff, that's what I would say.
Yeah, hormones
Okay.
are complex. That's an
Yeah.
understatement.
Yeah. Yeah.
Um, Jumping back to kind of where you've seen endo, we do have someone who's curious. Have you ever seen it in the SI joint, or would you ever think endo, like you had said, could it be elsewhere and then creating pain um, in the
Yeah. I
SI
mean,
joint?
my general comment to that is that I think it's probably referred pain. I think the pelvic floor and the pelvis and the back and the hips and the legs and things, when a lot of people describe cyclic pain, they're describing a referred pain from inflammation that's radiating down that nerve pathway and affecting that end organ point. So it would be very unlikely and really sort of impossible to deal with, unfortunately, like someone if they actually had endometriosis in their hip socket or something. You can't, I mean, unfortunately, what are you going to do with that? Do a hip replacement, maybe, I don't know, but that's not my department. So uh, so I think what we're kind of dealing with more, I have to go with the line of thinking that it's a referred pain, and we're going to tackle it from the perspective of dealing with that symptom in the pelvis, and then doing, you know, pelvic floor physical therapy and other nerve modulating strategies. Because people get so a little foray into the concept of centralized pain. Okay. So people develop, they become sensitized to pain when they have regular cyclic repetitive pain patterns, and their nociceptors, or their pain sensing nerves, become amplified, and they develop musculoskeletal and nervous system dysfunction of the pelvic floor, where everything in many people gets very tight and sort of this locked down pelvis quality. And it's just sort of your body always being on high fire mode in response to pain. And so that's where it's important to kind of think about a staged multidisciplinary process, whereby hopefully with surgery, we're getting to more of a reset point where that thing that's causing that repetitive pain firing is diminished. Also maybe a hormonal approach or whatever. And then the physical therapy piece is going to help unwind some of that tension and that chronic musculoskeletal and nervous system fatigue and dysfunction that's built up over years for many people. And so we have to understand that just doing surgery is not likely for most people going to achieve an optimal result, and it's going to take more steps.
Yeah, that centralized pain, I think we're going to have to do a whole nother session
Yeah,
on that,
yeah,
and
it's a
physical
big topic
therapy.
for sure.
And because, yes, obviously pain management is a massive
Yeah,
issue with endo. So
yeah.
very good. Um, so we had a question right in, which Kate and I both really enjoyed. And you had mentioned how you get referrals from other OBGs or
Mhm.
primary clinics or primary physicians. And so
Mhm.
what can other medical professionals do for a workup to kind of help you with gathering the essential information?
Yeah, I mean, I think any testing that makes sense in those, because I mean, obviously all physicians have the ability to order tests like ultrasounds and MRIs and things like that, and so if that provider feels comfortable that that's a good thing for the patient to have, I think it only adds information. It may not be necessarily confirming or showing anything, but that's also helpful, in a lot of cases. The only thing I would say is I really want to try to have people avoid doing surgery when they don't have the ability to handle a certain situation. So that, I mean, I also say that with a grain of salt, because I can't do every surgery on every patient, and there's just too many people out there, and I don't want to. But I do want people to try to have the best possible, most impactful surgical approach that they can. And so I tried it when I educate doctors about endometriosis. I try to make sure that people are asking the right questions, that they try to know what they're getting themselves into when they consider a surgical approach, and then, whether or not they have the training and experience to do the job that they can for a certain situation. And so I would rather have somebody go in and, see something that they obviously know is they're not in their wheelhouse of comfort, and stop and, have that post-op appointment with the patient and say, hey, I think you'd be better served by having surgery with a more experienced operator, based on what we found in there, rather than trying to do something that could be dangerous for a patient. So, um, stepwise, as far as a workup, I mean, history gathering, physical exam, and sometimes testing like ultrasound and MRI are probably the most helpful. But also just trying, like, most people, the vast majority of people that come to me have been on 4 different types of birth control. They've tried different things, and that's helpful because it's like, okay, it sort of checks the list of what worked, what didn't, what side effects did you have, why didn't it work, and that all adds information to the next best step for somebody. Um, so I don't know, I guess if I had like could design like a handbook for providers, it probably would include, you know, um, a detailed history of physical exam and an ultrasound. And then,
Okay.
just kind of beyond that, depends on the scenario, you know.
Okay. And anything kind of specific with doing those ultrasounds, or would you recommend an MRI? And do
Well,
you do
it's a
you like
good
to
point.
see images, or do you just like to see the report on those?
Mm. There's not really a cut and dry answer there. Okay. So sometimes I'll see ultrasound reports that make me think, okay, I probably want to have that repeated. And then, I generally have really good trust in our ultrasonographers because we've spent a lot of time talking about things that are related to endometriosis. And then also they just have a lot of experience because of the volume that we have come through. So I think the idea of knowing what you're looking for as far as components of cysts, how ovaries generally move in the pelvis under the presence of ultrasound with a transvaginal probe. Um, Sometimes you can get the sense that ovaries are adherent to the pelvic sidewall or kind of fixed or stuck, or the same with the uterus. So just kind of having someone that can be comfortable with sort of dynamic ultrasound is important. Um, and, you know, sometimes imaging in general is not helpful, oftentimes, unfortunately, and that's another one of the big um, confounders about endometriosis management workups is that you just don't get a lot from imaging. I still do it because you may find something, you know, and then that could be really helpful in framing what to do next. But a normal ultrasound does not mean that you don't have endo. A normal MRI does not mean that you don't have endo. My typical strategy for people when I order an MRI is if I really strongly suspect that they have deeply infiltrative endo, and it's could be affecting their colon. And sometimes we want to use that to, when I order MRI of the pelvis with contrast, we're looking at them making really fine slices of views through the colon to really see the layers in detail. And that can be helpful as far as looking at like potential depth of invasion of a lesion. And then also colonoscopy is another important strategy. So a lot of people, and this is one thing that I have to always constantly sort when I'm ordering workups for people, is because just about everybody has GI symptoms. I mean, everybody on this participating in this chat that has endometriosis could probably somewhat correlate some GI symptom to their disease. And so with every person that has severe bloating or even mucus or sometimes a little bit of blood in their stool, I can't order a colorectal surgery consult, a colonoscopy, and a co-surgical management approach to every single patient because it would be really low yield, and just not effective for the healthcare system and getting people care, you know? So I have to be able to kind of try to sort through how pressing of a need I feel like something like a colonoscopy is for a person, and then use that going into a surgery to know sometimes do we get, I often work closely, as you guys may know, with Dr. Cameron Janabzadeh from Specialists in General Surgery, or also Dr. Courtney Kemp from SIGS. Sometimes we'll utilize Dr. Kyle Barker from Colorectal Associates with Voyage Health. But, I would say those cases are pretty rare. Generally speaking, I probably do 1 to 2 combo cases a month, roughly. And in those cases, there's probably at least a 50% or greater chance that that person would have to have a bowel resection during that surgery because it's just that much of a indicator based on their workup. So,
Okay, gotcha. And then, so kind of, yeah, jumping into the surgery, which obviously there's excision surgery is step one, but then there's multiple more steps after that to kind of manage your life with endo. But could you kind of explain a little bit, about how you approach, in addition, robotic surgery? We got a question about hepatic feedback, that there's been some research on that, or any other kind of surgical options that you would do.
well, I think, the idea is that however surgery is done, the most important point is the operator and not necessarily the tool, so I tend to do my surgeries robotically because in my hands and in my training and experience, that to me is what's going to give me the best result. Just because, and there's different reasons why I like it, namely it's high definition 3D vision. I have wristed motion with a lot of dexterity inside through working through small ports that you don't necessarily have with straight stick laparoscopy techniques. But there's many excellent straight stick laparoscopists out there that do excellent excisional work. And so it tends to be a little bit of an older school modality or mentality, but not necessarily. It just depends on where somebody trained, So most of us around the country and around the world that are doing this type of work are people that have come through fellowship training through the AAGL, which is the American Association of GYN Laparoscopy. And that's how I got my specialty certification in minimally invasive gynecology, was through the AAGL. And it just so happened that the program that I was in, which was at Henry Ford Health System in Detroit, it was a very robotic heavy training program. And so that's sort of what became my go-to, and so, that the answer is really whatever the surgeon that you have chosen to trust to do your case says they're going to get the best result with, you should go with that, and ask the questions as to why, why they believe what they believe about that modality, and you know make sure that it makes sense to you as to what they're describing and why. And um then we just kind of have to say, obviously the robot's not going to operate on you without someone driving it and controlling it, and using it in the right way. So it's really more about um the experience of the person doing it than about the technique or the tool.
Yep. No, thank you. Thank you for that. And then kind of a follow-up. So obviously excision surgery is to remove the endometriosis that is growing.
Yeah.
But in addition to those growths, there can also be adhesions. There can be
Mhm.
scar tissue from previous surgeries or just from the endo.
Mhm.
Um, Do you utilize or do you know of any kind of prevention techniques for those? Depending on the person, that may be even more of an issue to them than the endo that needs to be removed.
Yeah. Well, I think there's a general understanding that anytime you cut something, it can form a scar, and so different people form scars at different rates and severity to others. Some people are very prone to it, and some people are very not. And so, primarily the concept that I utilize when it comes to trying to prevent adhesions is minimally invasive. So we're trying to minimally handle tissues that don't need to be. We're trying to avoid a lot of blunt pulling, tugging, packing away bowels, spreading, all these things that you do with open surgery. We're trying to avoid a lot of oozing, so we're trying to keep the tissues very dry and use meticulous hemostasis and bleeding control throughout the dissection. So using little zaps of cautery and bipolar and different things to kind of really make sure my field is dry as I'm working and there's not blood oozing everywhere. Um, using a lot of irrigation so that I can see really well and keep my field clean, and then trying to get out all those little residual cells that are in there at the end by doing a lot of irrigation. And then once I'm done and I've done the best that I can to keep it really dry from a bleeding standpoint, I'll put a couple different agents in. There's three that I use. One is called Interseed, which is a little bit of a netting kind of plant-based cellulose-based product that looks like a little sheet that's like a dryer sheet almost look to it. It's a little flexible, papery kind of thing. And that can be placed up against the pelvic sidewall, like under an ovary or wrapping around an ovary or over a raw surface. And what that does is it liquefies and kind of gelatinizes over the course of about a week's time. But during that time, the peritoneum that was stripped away underneath that endo lesion is healing and reforming without endo behind it or on it. And so then during that reforming process, it's
Sorry,
keeping
I'm gonna
something.
jump in real quick. So
Yep.
peritoneum, for anyone who's not a
Yes. Sorry.
scientist, is the lining, your lining around your organs, correct?
Yes. So generally the entire lining of the abdominal wall and the pelvic floor and the abdominal cavity and the organs is peritoneum. And so that's where you can see these lesions of endo growing into often. And then that's sort of the area where I will kind of excise in a circumferential kind of wide margin around that lesion, removing the peritoneum around it, and leaving behind kind of a bed, like a raw surface area, a little like hole essentially where the lesion was. And that's going to like fill in and heal, just similar to like what a scar or a scab would turn into a scar maybe or something, on your skin. But during that process, we want to try to avoid like your bowel from sticking to that spot or your ovary from sticking to that spot. And so that's the purpose and the intent of adhesion barriers. I'll use Interseed. I'll use a product called Surgicel powder, which is kind of a white puff powder that you can kind of put a little straw in there through one of the ports and kind of puff it out around the tissues. And then I'll use a product called Tisseal, which is a spray. It's like a gel. There's a little kind of squirter thing that kind of sprays a fine mist over the surface of an area. And so usually a common place to use that is like with a hysterectomy when I'm worried about just a lot of dissection around, like there's a lot of bowel involvement or something, and I've done a hyst, and I just want to make sure we keep it super dry so we minimize abscess formation. I'll use Tisseal down there, that spray. So kind of technical, but the idea is generally that keeping it dry and trying to minimize raw surfaces so that things don't heal together and stick together. There's an interesting concept being considered in the area of placental cells. Okay, so taking human placental cells and it can be made into sheets of material similar to interseed, and using that as a different kind of barrier material, or it may have regenerative properties to help the tissue heal better. It's being used in joint spaces right now, and I'm going to be working with a company called BioLeave to do a trial on people having endosurgery, and using it in that setting. Um, so, there's different things that are kind of imagined as far as adhesion barriers, and ultimately the difficult point is that we don't want to go back in your body and see what happened to your adhesion, with your adhesions if we can help it. So we're trying to not do second look surgeries. But, so sometimes the endpoint can be pain or, just normal function of your organs and stuff like that. Hopefully indicating that things are sitting and moving normally and they're not stuck, but.
Okay. And then we just got a question in, do you know anything about using PRP for adhesions?
Yeah, I think it's another concept that people have tried, and it's similar to kind of a regenerative tissue concept, increasing blood flow to a tissue area where it's applied to kind of help speed the healing process of that tissue that's been excised and resected. The data comes from animal models where, people do go back in and do like second look laparoscopies on pigs and sheep and things like that and kind of see what the result is, as far as the healing. And you can extrapolate that to humans, but I mean, any human data is conjecture, honestly, because there's not enough second look laparoscopy data on PRP to really know if it makes a difference.
Okay. Yeah,
Yeah.
but there's multiple options out there, and
Yes.
you're utilizing several of them, so that is
Yeah.
good because adhesions can be a beast.
Yes.
So I know we touched a little bit on, how to delay additional surgeries post, an initial excision one, I should say. But kind of for follow-up, what things we as endo warriors should consider before additional surgeries? Anything else that you can kind of recommend? I know we've talked about several, but throw that out there again.
Probably the biggest one is, I'll go back to the goals concept. So
Yeah.
if somebody's trying to get pregnant and they have a lot of symptoms, or not that they're even trying to get pregnant, just that they want to keep that as a future option or keep it on the table as something they would consider in the future, and they have a lot of symptoms, and we're not trying to do a hormonal suppressive method, it sort of sorts itself out to a surgical approach, sometimes being the only reasonable option for somebody. And so again, I'll say I try really hard not to do repetitive surgeries on people and come up with the multidisciplinary, multimodal strategy for nerve pain, period pain, GI symptoms, etc., that can avoid surgery, repetitive surgery for somebody. So I'm definitely not quick to jump to that as a again, modality, but it really has to be tailored to the person, and we have to kind of talk through what we've tried, what we could consider, what your goals are to really, know, and sort of all the things we've already touched on could be in play,
Yep. Yep. All right. So I know we've brought up infertility, pregnancy a little bit. What is kind of your recommendation as far as the time frame? Do you think there's better time frame post excision, or does that vary for patients?
Yeah, and so I think what a common talking point around endometriosis and fertility is, and endo can impact fertility in a couple different ways primarily. One is structural, in that it can distort your anatomy and it can make things like ovulation not happen properly with cysts or stuck ovaries. It can cause tubal occlusions, narrowing or blocking or dilating of the tubes, or the little fimbria at the end of the tubes that kind of get that need to kind of move freely to sweep an egg up in. It can get kind of agglutinated or stuck. And so that is one way that it can affect infertility. And then additionally, just the inflammation that endo causes can also primarily affect infertility. And so a lot of people that have perfectly normal anatomy per se that pass a tubal dye test and that have, nothing obvious that's like distorting their anatomy can still have infertility because the inflammation caused by endometriosis can affect the normal motility of egg and sperm through a tube, or can distort the little finger-like cilia action in the fallopian tubes and compromise fertility that way. And then so the idea of endo excision and debulking and removing endo is to knock down inflammation that's creating infertility issues. So I think, when it comes to infertility, I try not to use that as a primary endpoint for surgical success, because there's not enough good data to say that it really, really, conveys that result. I try to look at it as more of a secondary endpoint where we're using symptoms as the primary driver for why we should do surgery, and the success of the surgery being alleviation of those symptoms, with a secondary goal being able to conceive successfully. So from the time frame perspective, it depends on a person's age. It depends on what other workup they've had. So like if they're young in their 20s, whatever, and they we find endo and they've been dealing with infertility for just a little while, and of course that can be variable depending on your perspective, but and they're willing to like have surgery and then give it some more years of trying or whatever, fine. But if someone's 35 and we're kind of trying to hang all of our hope on this surgery as like solving their fertility journey for them, things get a little tougher, and so I try to kind of be honest with people, but do the best that I can to get everything as optimized for them as possible. And then we have kind of a reasonable time frame for if trying to achieve spontaneous conception is important to them and their partner, then we say, okay, depending on the severity of the disease, depending on the success of the full removal of endo, and kind of me feeling good about the thoroughness of things, we say maybe you have a 6 to 9 month time frame of trying. And then after that, if you haven't been able to conceive, let's not kind of continue to go down the road of maybe hoping, but let's go more to a more aggressive approach and seeing like a reproductive specialist and considering those steps. And that's a whole nother topic, but whether it's IUI or injections or or stimulation of the ovaries, Clomid, letrozole, IVF, etc. So yeah, the fertility is a huge piece to all this, and I
Yes.
totally understand it. I just try to be kind of direct with people about that not being a primary endpoint, but also trying to give people hope that, I mean, I've seen lots and lots of people that have, and some of you have personal stories about that have endo removed and debulked and cleaned up, and then you're able to get pregnant. So that's what we're hoping for, obviously, without having to go down the road of advanced therapies and cost and things like that hopefully you don't need, but you may. So
Yeah, no, I think, the 6 to 9 months, that sounds reasonable. It can feel like an eternity.
yeah.
And I mean, I have a personal story as well. I was trying for about a year and a half before I had surgery with Dr. Palmer. Month and a half after surgery was the first time we tried, and ended up pregnant, even though I had appointments with a reproductive endocrinologist already
Mm.
scheduled because I have no patience, and an IUI scheduled. I called to say I'm pregnant. I'm not scheduling an IUI. So it's definitely
Yeah,
possible. We also know people who they need IVF, like because of how
absolutely.
endo affects things,
Yes.
you know, that step is necessary with what is going on with the system.
Mhm.
So,
Yep.
yep,
It's complicated, but
yes.
I'll try to help you the best that I can, basically. So,
Yep. And we are getting some questions in the chat, so I'm gonna jump over there. So let's see here. We've got some questions kind of about PCOS and endo, as well as, and I always say this word wrong, adenomyosis.
mhm,
You know, how does that kind of affect fertility in general? And if that's not your wheelhouse, that's okay. We are having Dr. Khan on next week,
mhm.
next Tuesday, and he is also a reproductive endocrinologist. But
Yeah, I think Dr. Khan is a great resource for you guys. So I think that you'll really enjoy that chat. He's super knowledgeable and like extremely smart about how he manages both infertility and endo. But um, I think generally speaking, you can mostly separate PCOS from endo. Okay, I'll say that. A lot of people want to lump them together into the same bucket, and a lot of people come to me and say, I have so much pain, and it's either PCOS or endo. And okay, probably not. They can be similar, related in ways that are related to a systemic problem that's something related to an autoimmune problem. Okay, so they tend to kind of travel together for a lot of people. But PCOS is not going to cause the pain and the symptoms that endo causes, but it can cause ovulatory dysfunction, and it can cause basically people to have missed, skipped, and delayed periods, and just generally not ovulate on a regular basis through the process of doing what it's doing. And so ultimately you're going to want to sort of try to separate those in the workup process and say sometimes surgery is indicated for endo, but it doesn't necessarily do anything for PCOS, and that's typically more of a medically managed problem where you would undergo, that a lot of people are successful in things like letrozole, for helping super ovulate through the um, process of what happens to your ovaries when you have PCOS, where they get kind of hardened and little tiny follicles form and ovulation becomes difficult. So how do I address PCOS? I tend to try to focus on endometriosis and tend to let, from a more basic workup standpoint, I tend to let a couple of my partners that do a lot more of infertility management, Dr. Taryn McAvoy and Dr. Anna Meyer, handle that aspect of it, and I'll refer people to them within my practice. And then, of course, I'll send a lot of people to REI. So, just depends on what the person wants to do, what kind of workup they've already had, cost considerations, a lot of different factors, you know. Adenomyosis, similar to endometriosis in that it's a disease state related to abnormal malplaced endometrial-like cells. Adenomyosis tends to have a diffuse nature where the endometrium, which is the lining of your uterus that you build and shed every month, tends to kind of invade in little finger-like patterns into the myometrium, or the muscle layers of the uterus. And that can, like I was describing at the beginning, create heavy and irregular and problematic bleeding patterns for people. It's a very inflammatory issue, so I would say it could be contributory to recurrent pregnancy loss and/or inability of normal implantation to occur in the endometrium. I would say that I generally tend to see less issues related to infertility with adeno, just anecdotally, than with endo. But it's a little bit hard to sort out who has what and what's causing it, because they often do travel together for most people.
okay, that's interesting. Yeah, we had another question that had gotten written in about uterus resection for adenomyosis.
Mhm.
I don't know if you are aware of that with any, fertility outcomes.
Yeah. Well, it's a little bit of a complex question, but I think the easy answer is that usually adenomyosis is diffuse, and it's not able to be removed without compromising the function of the uterus. And so by and large, it's a hysterectomy. That's the primary surgical modality for definitive management of adeno. But sometimes people do have focal lesions. I just removed last week probably a 10 centimeter adenomyoma from somebody off the fundus of their uterus and reconstructed the uterus. And basically she only had it in one spot randomly, but you can see the distinction between a fibroid, which is a leiomyoma, where it has a defined plane. It's like a circular oval super ball kind of shape that has a capsule around it, versus an adenomyoma, which is more diffuse and more like an area, a broader area. And so when we're talking about excising adeno and doing like uterine wedge resections and stuff, it really has to be going after a specific focal area that can be excised out and then repaired to preserve the uterine function. And those are difficult surgeries, and it's hard to know when you go into those, if you're going to be able to do it without compromising the tubal function and things like that. So those are tough. Yeah.
Yeah, I would expect it may or may not help or make things more difficult. So, yeah. You see the next one there?
Yeah. Yeah, it's a good question. I mean, I think that gets a little bit into the weeds for me as far as how I would steer somebody. It's definitely more of an REI kind of decision tree, probably. So it's the thoughts on the receptiva diagnosis in IVF with using Lupron to overcome recurrent pregnancy loss instead of surgery. So the idea behind Lupron is that it's going to take you down to a near zero estrogen state for the time that you're on it, and put you into a fully hormonally menopausal state, which the idea, again, when we're talking about estrogen and how it drives endometriosis, is that if you take away its fuel, take away its source, it's going to likely shrink and become less active and less inflammatory to the tissues. And so the idea behind it pre-IVF is you're going to hit the disease state with this chemical, this medication option that's going to suppress your estrogen. It's going to shrink away the endo temporarily. We know it'll reoccur if you don't continue to treat it with that. And for most people, being on long-term Lupron therapy is not doable. It's not reasonable. It's not safe. It's not the right thing to do. They can't tolerate, et cetera. There's a lot of reasons. But the idea is to kind of medically suppress the endo down and then do the IVF, before it has a chance to reoccur. And I think that that's a reasonable strategy. I don't know, I wouldn't be able to speak to outcomes as far as success rates, one versus the other, or comparing them to each other. I just think that that's kind of the concept. And for somebody that really wants to try to avoid surgery for whatever reasons that they have, and that seems like a good option to try, then that's the concept. That's what you're going for there. And it certainly could work.
Very cool. All right. And I did get one question here about someone asking about endo causing gastroparesis.
Sure.
Do you have any thoughts on that?
Hard to say. I mean, I would say my general thought with endo is it tends to cause increased GI motility because it's inflammatory. So most people that have endo tend to have loose stools, diarrhea, mucousy stools during their menses. And it's more rare to have like the bowels slow down, which is really what gastroparesis is talking about generally. But certainly if like an inflamed area of endo, or there's a stuck loop of bowel or something that's causing it to kind of decrease the normal motility of stool and digesting food and everything moving through your bowels and your colon, it affects its transit time and stuff from like a kinked spot or something like that. I could see that it certainly could be related. Those are cases more where you think it's got to be bowel generally and bowel adhesion related. That's the issue. And we're going to think about going in there with probably a general surgeon, like a Dr. Kemp type to help sort that out and do lysis of bowel adhesions and stuff in a case like that where it's pretty significant symptom wise. But
Okay.
yep.
Cool. So time for just maybe one or two more. So
Okay.
the first one we've got here is, is there something that makes you hopeful or excited for this field in endometriosis research? Are you kind of aware of any new research on endo or new treatment options to manage symptoms?
There's a lot of things out there that are being considered, and probably the most recent amount of a lot of money being put into endometriosis were the studies that were done related to the elagolix trials and religolix trials related to Orilissa and Myfembree, and just demonstrating that those medications did reduce pain in people that took them, and that had active endo. But other things that are being studied are things to try to predict endo. So there's a couple trials, one that'll be coming out in fall of this year called the Empower study that's being done to look at microRNA and using basically a way to try to analyze blood to see if we can recognize clinical markers that are that are related in people that have endo. There's also a study about using menstrual blood in a similar way to look at the predictive value of different biomarkers seen in there as far as endometriosis in people. So I think what would be most exciting to me and to everybody is things that can increase our predictive value knowledge of endo in somebody without surgery, you know? And so I think if there's any traction to these couple studies and others like that are out there that are ongoing, and I think that would be really exciting to see if we can find things that we can actually test in people that are going to show us a high likelihood of having it, because we just don't have anything like that, at this point in time.
Thank you. And then, yeah, I think the next one is kind of timeline wise for getting in with you.
Sure. Well, I would say kind of just broad stroke, we'll do a consult. You'll probably wait a couple months to get in for that consult from the time that you engage with our schedulers and do the end and the intake form. And then typically my surgery schedule is about 3 months out, roughly. I usually operate 2 full days a week on Mondays and Wednesdays, and have 3 different primary sites that I operate at. 2 Maple Grove sites, the hospital, the surgery center, and then the Edina Specialty Surgery Center. So, I mean, we try to be pretty flexible with, I work a lot, but I try to also have some time when I'm not working. But I mean, we try to be pretty reasonable about getting people in as timely as manner as possible. And I think one of the things that makes my practice as a private practice, it allows me to do a lot of volume just because I don't really do any teaching or training of residents or have a lot of red tape when it comes to scheduling or block time. I kind of have, a lot of access to surgery time. And so I just try to use it as much as I can. So, yeah.
All righty.
Oh yeah, you noticed. Thanks. I was trying to do my best to use gender inclusive language because I know that's very important. And so it's important to me too.
It is very important. The way to decipher pain between adenomyosis and endo. And I know we talked a little bit about reverse with a hysterectomy, but
well, another buzzword or buzz phrase that many of you have probably heard me say in the consult is I try to sort out uterine symptoms from extrauterine symptoms. And so most of the time, adenomyosis tends to be, primarily uterine symptoms, meaning centralized pain and cramping, bleeding irregularities, bleeding with intercourse, mid-cycle bleeding, prolonged heavy periods. And of course, endo can also have those things, but generally those are considered uterine symptoms compared to like radiating pain, ovulatory pain, bowel symptoms, bladder symptoms. Those tend to be more endo-y. And so when I'm going down the line of questioning, trying to sort through a treatment plan for people, I try to get pretty narrow on the specifics of their symptoms, and then that helps me sort out sometimes endo versus adeno. So
Okay. All right, we're gonna do this one final question because we got
okay.
2 minutes left. So obviously you work with a team at Oakdale, and so you have the nutritionist and the pelvic floor physical therapist. Kind of what's the timeline, of getting in with them?
Yeah. So what I always try to do is when I have a consult with somebody and we decide on a surgical approach, or we're deciding on like, okay, you're going to follow up in 3 months or whatever, during that time frame, we're trying to do other things at the same time, and so we're trying to implement a medical hormonal therapy strategy. We're introducing some new meds like pelvic pain, vaginal suppository, whatever it is. And we're also getting people in to start seeing physical therapy and nutrition during that time. So typically, now that we have 2 dedicated full-time PTs that are seeing people both in Blaine and Maple Grove every day, we're having a lot more success with getting people in a timely manner. Within the usually about a week or 2, you can get in. So, and maybe that waxes and wanes throughout the year or whatever, depending on the busyness and the volume. But it's a lot better than it used to be, where people were waiting like 2 months to see Sheree. So it's better, and I really try to actively work to get those other things going for people during that kind of waiting for me kind of in my schedule kind of time frame. So
Wonderful. Yeah, no, that helps. I know I started nutrition right away, and
yeah.
then pelvic floor PT we started post-surgery for me
Yeah.
until, yep. So,
All right. Well, I'll just wrap it up and I'll say,
yeah.
thank you guys so much for attending. I hope this was helpful information for a lot of people. And I know that this presentation will live on beyond this night, because it's going to be posted a lot of different places on social media and, on Endo Warriors site and probably on Oakdale's site and stuff too. So I hope that that continues to help people out there. But you guys are all warriors. And I think I love the work that I do, because it's the awesome patients I get to work with. And, I think you guys are amazing and go through a lot, and I'm here with you. I'm here for you. And I love doing what I do, and I'm excited to keep doing it. So thank you.
Thank you. Thank you so much for joining us. I think, yeah, definitely the need for this, and we will keep going with the additional doctors the next 3 weeks. So,
Sounds great. Enjoy that, and we'll
all right.
see you guys around. Thanks.
Yep.
All right.
Bye.
Bye.